I'll give you guys a couple more seconds, but yeah, the big elephant in the room is this big honking aortic dissection. So since that one was a little bit easy, what's the most common cause of aortic dissection? So I see a couple good ones. I see smoking, I see Marfan's, I see hypertension. Hypertension is probably the most common and is probably the most relevant. It is unfortunately a very devastating disease. Patients will complain of chest pain that is tearing or ripping, and it will move to the back sometimes. A lot of times, like, if you ever see a patient that tells you chest pain and they give you the minute it started. So like a lot of times chest pain will come on sort of insidiously and sort of get worse over time. They'll come in and say, all right, I was watching the second quarter of the game and it was bothering me, and by halftime it got pretty bad. It's like a dissection. Again, it's a tearing of the wall. They'll tell you, yeah, at 6:22, I started having chest pain. It was really bad because it starts like bang, and this can be a real problem. So to treat this, you would lower the blood pressure, because you don't want this to rupture, because if this ruptures, has a mortality of 90+% at that point. And it's all related to shear stress. The higher the blood pressure, the more shear stress is being placed on the wall. So you would give them medication to lower their blood pressure, like nicardipine, like esmolol, even labetalol. So you want to use those and lower the blood pressure, and then kindly call your friends in CT surgery and say, please help. Yeah, this is one you don't want to see. So yeah, there's the big one in there: hypertension, Marfan's, and someone mentioned smoking is more of a problem with aneurysm. Again, sudden onset chest pain, and it can tear arteries, and that may be what they give you in terms of like a tricky question. They may point you towards, unequal blood pressure is a sign that it is torn through a subclavian artery, or cardiac tamponade that is torn through like a coronary. So be very attuned for that. And the blood pressure will be high. And if it's not ascending or Stanford type A, you're going to do surgery on it. And this is what your aorta should look like. This is a nice aorta. Again, your pulmonary, I guess you guys can't see here. So here's your aorta, your pulmonary artery here, a little bit of your bronchi here. Here's the descending aorta. It's going to come all the way around. And there's your spinal cord and vertebral. And you can tell again, this one doesn't look like it has contrast on it. This one certainly has contrast. So widened mediastinum here. What do you guys think is happening here? So yeah, this could also just be a dissection. Not almost a trick question here. A lot of you guys didn't fall for that. I did see Alini put pulmonary anthrax, which in the right clinical situation is very true. I see a lot of tetralogy of Fallot. Not a bad answer, because it is Buddhish. This is probably too much of an adult for it to be tetralogy of Fallot, but I like the way you guys are thinking. Again, that pulmonary anthrax, excellent one. And this is, again, what a normal mediastinum is going to look like. Normal mediastinum, like Michael mentioned before, not incredibly sensitive, very specific. Specific for badness is the easiest way to think of it. If you see a widened mediastinum, you're thinking that something bad is happening, and you're just going to get a CT. That's going to be that's the nice thing about the ERs. Simple pathways here. This is bad. Let's get a CT.